There we go. Now Facebook ought to be coming alive right there. Good. Finally. So 4 o'clock and Fink and Friends. I'm Fink, your friends. That's what I said before, in case you missed that part. We've got a couple of different Instagram feeds. We've got CNYs, we've got Randy Finks, we've got Facebook and YouTube and LinkedIn right here. So it sure is good to see everybody on this Tuesday afternoon. Good afternoon to everyone, or good evening if that's the case. Looks like things are still pretty hot out there. I am back in Colorado Springs here, where I am the clinical director of IVF services at CNY Fertility in Colorado. And I spent last week in Miami, part of the week in Miami, at the Miami Center of Excellence, and so we did my last live from there. If you happen to watch it and you notice that I was sweating like a pig, it's because I was in a little room with the shades open, and it probably had to be about 105 degrees in that room despite the air conditioner. So it's nice to be back here in Colorado, where it was about 75 degrees this afternoon, and oh, what happened there? There we go. Now I think we're back. I started to lose one of those connections there. Well, so, there's a couple of things that came up this week, things that I wanted to talk about and mention. One of those things is kind of the way things go with fertility treatments here at CNY, and I wanted to talk a little bit about that. There is, and it's actually not just CNY, it's really kind of across the board. So the way we work here is that when you do a consult with us, it's usually a virtual consult, so we're having a phone call. They used to be done by video, but for some reason those ended, and now it's really by phone. We have the consultation, and then for your monitoring, you're either monitored at an outside facility, someplace closer to where you live, or at one of our CNY offices, and then you have your procedure at one of our CNY offices. Well, because of the fact that we have a lot of different providers here in our company, you may have the opportunity to be able to meet and to talk to a bunch of different providers. It is not necessarily always going to be the same provider each time. And so as a result of that, you may get differing opinions, that different people may tell you different things about different avenues and different possibilities, different ideas about how to approach a different problem, or maybe even a different way of looking at the same problem, trying to figure out what the issue is that you have. And sometimes people reflect back to me that is seen as a fault. And I will tell you, I don't think that that's a fault. I think that that's actually it's a good thing to be able to get multiple opinions. But the same thing will hold true if you are maybe have had some treatment at a different facility and then come to us for another opinion. Or sometimes what happens is that folks will have had treatment at a different facility and realize that the costs were just astronomically too high, and they didn't want to continue there. So they came to us because we are certainly the more affordable option, and come to find that, well, we do things a little different than the place that they were before. And that is not only not unusual, it's really to be expected. And I think that there is some impression that that fertility treatment or gynecology, or for that matter, medicine in general, is a binary system. It's black or white. It's X or O. There's one way to treat things, and with very few subjects in medicine is that actually the case, and certainly not in fertility. There are lots of different options. There are lots of different ways to approach a situation. So it is not at all uncommon or weird in any way to talk to different providers and to be given, somewhat different answers as it pertains to what's going on with your situation. Now, there are some kind of basic structural things that should be the same each time, but each of us us might think a little bit differently about how to create a medication protocol that is tailored to you and to what's going on in your world. Each of us may think a little differently about how to approach something that's not working right. And so that's not a bad thing, actually. That's a good thing. And it's also human nature, and it's also kind of medicine in general, that it's hard to get a group of people, especially highly educated people like medical providers, to agree that the sun is shining outside. So one might say, well, you know what, I think it's partly cloudy. Oh, says no, says the other one. No, it's mostly sunny. Oh, really? Because it looks like it's partly sunny to me, but more cloudy than not. Well, I mean, it depends on how you define cloudy versus partly cloudy. You know, there's just so many different ways to look at issues. So as frustrating as it may be to hear different things from different people, and sometimes you'll get different opinions from different nurses that you talk to going through the program, different nurse practitioners, PAs, physicians, and that's all just really to be expected, because there is no one way to do it right. So, what I would ask you to think about is embracing the fact that you have the ability to get multiple opinions on something that's actually pretty doggone important, wouldn't you say? I think so. Well, the second thing I wanted to talk about is sort of the overuse of the term PCOS and what PCOS, polycystic ovarian syndrome, means, or even polycystic ovaries. So, this terminology is something that's kind of thrown around a lot, and it oftentimes can mean different things to different people, because the definition of what we call polycystic ovarian syndrome can really somewhat be a moving target. There are situations that I will tell someone, well, you have what appears to be polycystic ovaries, and that may be different than true polycystic ovarian syndrome. So let's talk about that. The syndrome itself is defined by chronic anovulation. So you release the egg, that's ovulation. Anovulation is when you don't release the egg. So chronically not releasing an egg, or not regularly releasing the egg, with a regular frequency, that can be anovulation, and that is part and parcel to polycystic ovarian syndrome. Number two is the appearance of polycystic ovaries on ultrasound, and what they often look like. You know what? I should have brought a picture here to show you, but it's easy enough to Google image PCOS ovary, and you'll see that it looks like a chain of pearls, is what we call it. And these are multiple peripheral follicles. The follicle is the egg house. The periphery is around the outside of the ovary, and you see what looks like a little pearl necklace that goes all the way around. Those are the follicles that are not being ovulated, that are just hanging out, that are pretty easy to see by ultrasound. So that's criteria number two. Number three is that there's a laboratory evidence of hyperandrogenism. Androgen is like testosterone. It's the male hormones. And these hormone levels tend to be higher in women who have polycystic ovarian syndrome. And that can result in things like hair growth in places that you don't want to have hair growth. That can result in hair thinning in places that you do want to have hair growth. That can result in acne. That can result in some thickening and some darkening of the skin, say around the neck, under the arms, and in the groin. And that has a term. It's called acanthosis nigricans, and is often a sign of insulin resistance, which is another kind of metabolic problem that goes along with polycystic ovarian syndrome. Now, there are some people who will behave, or their bodies will behave, like they have PCOS, but they don't actually have the syndrome. So it may be that we check a common blood test that we do here is the AMH, right? The anti-Mullerian hormone. So we check your AMH, and that number may come back as high. So generally speaking, when it's above about a 5, we really consider that consistent with polycystic ovarian, or with PCO, as we'll call it. So that means that whether or not you have the syndrome, it suggests that your ovaries are going to respond as though you do. And what do I mean by that? It means that you're prone to being hyperstimulated. In most cases, it means that your ovaries are really going to pay pretty good attention to the medication that we're giving you in order to stimulate the ovaries. So we have to be careful in that situation not to give you too much so that the ovaries don't become too large and you can start having some issues that arise out of that. So being PCO or having a tendency towards PCO like symptoms does not necessarily mean PCOS or the polycystic ovarian syndrome, because there are many people who are PCO who have all the other heralds of having polycystic ovaries, but in fact release their egg in a regular, predictable fashion every month. Do they have polycystic ovarian syndrome? Well, I guess technically speaking, no, really, they probably do not. So that's another thing I wanted to talk about. We're going to get to your questions here in just a second, but I got another question that I was asked to speak about, and that is, what is Asherman's syndrome? Have you ever heard of Asherman's syndrome? Asherman's syndrome is a situation where you can develop scar tissue inside the uterine cavity. And when there's scar tissue in the uterine cavity, that can result in a damage to the endometrium, to the lining of the uterus, which ultimately can mean a problem with embryo implantation. So how do we find this? It's usually pretty straightforward to find. If we look with a camera, very easy to see it in that situation. But that's one of the reasons that we recommend that you evaluate your uterine cavity once a year, either with a hysteroscopy, which is a camera that goes inside the uterus so that we can see what it looks like on the inside, or with a saline sonogram, or also known as a sonohysterogram. Now, I think it's an important distinction to understand that the saline sonogram is a different test. It is not the same as an HSG. The HSG, or the dye test, is a test that we use to look at the shape of the uterus and to see if the fallopian tubes are open. Right? Pretty much most people remember having the HSG because it's not always a very pleasant experience, right? The saline sonogram is a little straw that goes in the uterine cavity, and a teaspoon of fluid is placed inside while we do a vaginal ultrasound. So it's an ultrasound test. It's not it is not an X-ray, and in so doing, we can tell you that the uterine cavity is normal. And HSG is not, I repeat and underscore, is not and should not be considered adequate screening alone of the uterine cavity. Why not? Well, you got to have something that's pretty big on the inside in order for the HSG to actually show that it's there. So saline sonogram can be done at the same time as the HSG, but once a year we recommend the saline sonogram. Especially if you're doing IVF, in my opinion, once you have had that HSG somewhere along the line to show that your tubes aren't working or whatever the situation may be, I don't think you need to do an HSG again. If there's some question about fluid being in the fallopian tubes, that may be a different issue, but HSG is not the best test for that anyway. So please evaluate your uterine cavity once a year if you have embryos and you're planning to do an embryo transfer, because you've invested really an awful lot, haven't you, in making those beautiful, perfect embryos. And so to know that the uterine cavity is just as beautiful and perfect, to me, is a very important thing. Saline sonogram or hysteroscopy. So that said, oh, by the way, Asherman's is what we started talking about, which is scar tissue, usually caused by some instrumenting of the uterine cavity. The other thing that's really probably more common to find is a polyp, and a polyp is a finger-like growth of tissue that sticks up here like a tree trunk or hangs down like an icicle. And basically what it's doing is that it's taking up valuable real estate that your embryo wants to use for implantation. So we don't want that stuff to be there. And it's also really reflective of some kind of issue in the cavity that we want to be able to fix. So you don't want that stuff. Make sure that your uterine cavity has been evaluated in the year, at least in the year around the time that you're doing your embryo transfer. So I talked for 16 whole minutes and somebody actually listened to me for a change. So now let's start hearing from you guys. We'll start over here with on the Facebook side. This comes from Angelica. Oh, it tells me I keep cutting in and out. I don't know. Hopefully you can hear me over there. Hello. Well, hopefully it's working there, but can someone be given something to someone who has low AMH? So the question is, what can we do for people who have a low ovarian reserve? Well, there are, in the IVF world, there are certain protocols that we use specifically for folks who have a lower ovarian reserve. What it suggests to us is that it's going to be an uphill climb to try to get the ovaries to produce eggs for us. And so that's, something that we kind of build into our protocol, specifically if your ovarian reserve is low. I believe very strongly in a book that is called It Starts with the Egg. In fact, I happen to have it right here. I think I show this just about every time I do a live. There's a list of supplements that comes from that book, specifically for folks who are planning to do IVF, for folks who have a diminished ovarian reserve, and specifically for embryo transfer. I'm happy to send you that list if you will Instagram message me at Randy Fink MD, and I will send you that protocol because there is an evidence-based list of things that we can use to try to help you with your diminished ovarian reserve, because the goal is to try to get the ovaries to respond as best we can under that scenario. So yes, there are things that we can do there. Well, let's take a look here at, here's Haley's mama. Hi, nice to see you. Haley Kavanaugh. Hi, Haley. Nice to see you there. It looks like Carrera Webster just ordered meds. So exciting. Boy, it's a Wandering Wild. I like that name. It's good to see everybody here today. So we'll talk. Let's start here with Valeska, who tells me, so sad and disappointed. We had a chemical pregnancy for the second time and still haven't received a phone call from CNY. We used the Colorado location. That's not a typical thing. So that makes me wonder if we actually got the result. So if it was done here locally, you should have had some information there. Valeska, if you would please Instagram me and I will follow up on that. Again, that's Randy Fink MD. You're on the CNY side right here. Because yeah, we need to have some follow-up on that. Not the way it's supposed to be. Hi, Jackie Drew. Haley's mama 13 says, I have a question. I have is a dysplastic kidney related with IVF, even if we had the embryo PGT tested? You are 28 weeks pregnant. So good question. Really what it's asking there, Haley's mama, is PGT adequate to be able to determine if everything is normal in an embryo? And the answer to that is no. So a dysplastic kidney typically means that when they're doing her prenatal ultrasound, one of the things that they look for is they look to see the kidneys in the baby. And so it may be that they saw one kidney, they couldn't see the other, or that one of the kidneys looked very small and didn't appear to be growing normally. Well, if that was due to a chromosomal issue, like something in the genes, something in the genetic, then yeah, you would probably know that because your PGT, while not being a perfect test, has tested the chromosomes in your embryo. My guess is that it has nothing to do with chromosomes. It's just an isolated situation. I hate to call it a birth defect because that has such a very negative and frightening implication, but it is an abnormality in the baby that's not genetic. Fortunately, we can all really live with one kidney. So if there's one kidney that's not functioning there, that should not mean anything really very dramatic, God willing, for your baby, Haley. So best of luck there. We're going to take a look over here at the Randy Fink MD Instagram. Thanks all you guys for being here. Hello, Amber. Let's see, just finished my egg retrieval. What is a day 3 1PN embryo? So when they say that term PN, that's referring to a pronucleus, and that's an embryonic structure that develops as cells are dividing. It's usually what's called a 2PN. And a 2PN is pretty much a normal thing. If it's a 1PN, it means that they can only see one of those structures rather than two. But it doesn't necessarily mean that there's anything that's wrong with the embryo. The day 3 embryo just means it's a day 3 embryo as opposed to a blastocyst. And when you're limited in the number of embryos, we generally recommend that you consider transferring or freezing or doing what you're going to do with your embryo on day 3 rather than growing it out to blast, because it may not make it. And we really want you to have something that can go back in your body, because your body is always going to be a better place than what we have in the laboratory. So I see Barbara is here. Hi, Barbara from Miami, my wonderful medical assistant at the Miami Center of Excellence. And let's see, hi to Eileen. Shanna asks, is it possible to do an ERA and an Emma Alice test and still move forward with the transfer in that same cycle? For instance, doing these tests the day before the planned transfer. So you got a bunch of things I want to talk about there, my friend. The first is to answer your question, no. The answer is no. No. And the reason is because we don't want to be touching that lining at all if we're going to be placing your priceless embryo inside. We want it to be pristine. We want it to be a perfect environment that is untouched by anything. So sticking something in to do a biopsy is something that we don't want to do if we're going to be doing an embryo transfer in that same cycle. Now, things are a little different if we're doing like an HCG wash or a PRP wash, sometimes even a Neupogen wash. These things are placing some fluid on the inside. So we're washing out that lining, we're bathing that lining, but we're not actually sticking something in to suck a piece of it out. So no biopsy during a transfer cycle. Now, the other thing that's of interest there is that you talk about the ERA and the Emma and the Alice. And these tests have really taken on a very different significance lately, meaning to say that their value is really, truly questionable. So the ERA used to be something that we would regularly tell people that we wanted them to do, an endometrial receptivity assay. Nowadays, the data shows us that there's really no difference in the pregnancy rates from people who do an ERA and the people who do not. So there's many nuances in there, and there are some situations where it may be a test of last result. You know, if you've had multiple unsuccessful euploid embryos, for instance, transferred, we might think about it, but it is not something I would routinely recommend to anyone anymore. The Emma and the Alice test are both tests that look for infection in the lining of the uterus. And well, to be honest with you, we can probably do that in other ways that aren't as expensive. So not always a great test. So just because you read about it, for example, on social media or on the internet, doesn't necessarily mean that it's a good idea. And that's the perfect example. What else we have here? Wandering Wild. I just like to say that. Wandering Wild. How can I improve my ratio of PGT normal embryos as a 41-year-old? I had a beautiful first embryo retrieval cycle all the way until I got my PGT results back, only 1 normal out of 8. What can I change this time? Well, the truth there, if you believe it, Ms. Wild, is that, this has to do with the eggs in your ovaries. It doesn't have anything to do with the retrieval cycle or with any of the medications or with anything that was done to stimulate your ovaries. This has to do with the eggs that came. And certainly as we mature, and that is always the term I prefer to use, we mature. As we mature, the DNA, the genetic material in our eggs just becomes less stable. And so we're, even in nature, we're more likely to produce an embryo that has a chromosomal problem that results in nature, it often would result in a miscarriage, or it just, in IVF terms, it simply may not implant. So now you did the testing, and the purpose of the testing is to try to find which are the embryos that have the greatest probability of being able to get us pregnant. Would you agree? That's the goal, in my opinion, of PGT. We can take a big group of embryos and say, okay, these are the ones that appear to be chromosomally normal, even though the testing is not perfect. These appear to be chromosomally normal, so those are going to have our highest probability of success with IVF, and that's a 60% probability of being able to get us a pregnancy. Well, so can we change that at all? There are some people who would tell you that you can't change it because it's nature, it's biology, it's kind of just what happens over the course of our lives as we grow more mature. Well, I would say there probably are some things that you can do that improve egg quality, that may improve the possibility of obtaining euploid or chromosomally normal embryos. What are those things? Number one, it is the supplement protocol that is associated, the evidence-based protocol associated with the book. It starts with the egg. That's actually probably one of the reasons that the lady here, Rebecca Fett, that's why she wrote the book, because she herself suffered from a diminished ovarian reserve at a premature age and was trying to both improve her ovarian reserve and her egg quality. And what they determined from that, what the evidence seems to suggest is that, yes, aging, as it were, has the propensity to damage DNA, to cause an initial insult in our genetic material. But something else happens to that DNA, usually in approximately the 2 to 3 months before those eggs are recruited by the body to be prepared for ovulation. So you have a window there to potentially be able to repair some age-damaged DNA. And again, nobody's ever been inside the cells and run a little machine along, Geiger counter or something along the DNA to be able to say exactly how that happens. But we know in the human body that we do have a DNA repair mechanism. For example, another way to think about it, our skin is very prone to damage from the sun. As a result, people get skin cancer, right? Not all skin cancers are sun related, but a vast majority, a lot of them are. Well, we can get precancers on the skin that can heal. How in the heck does that happen? Well, those precancers can heal because our body has the ability to repair some damaged DNA. Look also at getting a pap smear, everybody's favorite test, right? Well, if you've ever had an abnormal pap, which is extremely common. It's not a big deal, really. It's scary when it happens, but it's not a big deal because in most cases, your body will heal that. If you had an abnormal pap at some point in your life, you probably know that, well, it's not abnormal forever in most cases because your body fixes the problem. The same thing can happen at the level of the ovaries and with the DNA that's in our eggs, it's believed. So there is a specific list of supplements for diminished ovarian reserve and even for normal ovarian reserve that has the potential to heal some of that damaged DNA, or to at least aid in the body's ability to heal that damage. Secondly, there's a medication called metformin. Metformin is a drug that we use to treat diabetes. It helps with people's blood sugar. It helps for people with polycystic ovaries. It helps to restore normal ovulation. But the other thing that it does is that in IVF terms, it helps with egg quality. So metformin would be another choice, as would growth hormone, or the medicine that we call Omnitrope. Omnitrope is the brand name, which is a daily injection you give. So those are the first three things that I would always reach for in someone who has had an issue with egg quality or with producing multiple aneuploid embryos. So certainly as we age, those are always going to be our go-to things. We talked before about Asherman's, and it looks like IVF done my best. It says, regarding Asherman's, can a hysteroscopy to remove scar tissue lead to further scar tissue? Is there a way to ensure that the scar tissue will heal appropriately? Does CNY use balloons? So one of the problems, and the same thing happens if you've had abdominal surgery, you can get scar tissue in your abdomen. And a lot of times that scar tissue can unfortunately result in problems. So there's a friend of mine in Miami. I haven't looked to see. She might actually be watching. Her longtime patient of mine, her husband has Crohn's disease. And as a result of very severe inflammatory bowel disease, eventually had to have the entire colon removed. And fortunately, they were able to kind of reconnect everything. So it kind of all works in there. But 3 or 4 times, he's had issues as a result of all these surgeries that he's had, that he develops an intestinal obstruction from that scar tissue. So yes, once you treat Asherman syndrome, you are always at risk for things scarring down again. And there are some things that we can do to try to prevent that from happening. One of those things is, well, the standard thing we would do is we give you some estrogen after that hysteroscopy. Estrogen is the language that the lining of the uterus speaks. And what it does is that it helps to boost the blood supply. It helps to boost your own tissue factors, your healing factors. And the other thing that can go along with that is PRP. PRP, or platelet-rich plasma, is when we take a tube of your blood and we're able to separate out those same kinds of tissue healing components, and we place that inside the uterine cavity. That is very effective at preventing the recurrence of scar tissue. You mentioned a balloon. You can indeed sometimes the uterine cavity can become so scarred that it actually looks like this. Oh, my watch is going to call the cops there. Sorry about that. That it looks like this. And so if we're able to go in and open up that cavity like so, then if we place a balloon on the inside, not a party balloon like you have at your birthday party, but a medical type of balloon in there that holds that cavity open, it may help to prevent that from kind of scarring back down again. So there are lots of different types of scar tissue. Sometimes it can be very, very dense and thick, and sometimes it's just filmy and light. So it really kind of depends on the situation that you have there. Let's see here. Fit and healthy. I was supposed to start meds on 7/23, but my cycle has still not showed up. You need to have a serious talk with that cycle of yours. I mean, that is the only thing I can think of. Take away the Xbox, take away the car keys, you need to lay down the law. You got to show that cycle who's boss. That is the only thing I can think of that's a realistic thing to say. Well, so your period's about a week late, and that happens sometimes. And sometimes it's just going to be late. So if your cycles are usually regular, but this time it's not, it may just be because you ovulated a little bit late. It may be because lots of different things. So sometimes we can give you some medication to induce that period. But the first thing I'd want to know is, well, did you release an egg this cycle? Because if you did, then that means you're going to get the period. It's just kind of a question of when. So if we're waiting and waiting, eventually I would say, well, usually we want to do a blood test, look at some hormone levels, and take a look at the ultrasound and see what's going on with the ovaries. So we can definitely give you a cycle, however. All right, let's take a look over at the Facebook side. What can I do for recurrent pregnancy loss? This comes from Fatima. Hi. They had me doing back-to-back IUIs that resulted in an ectopic pregnancy and now wants to push for IVF. Do you test for blood clotting disorders, and can being pre-diabetic cause miscarriages? So as far as blood sugar goes and miscarriages, the higher your blood sugar, the greater is the probability of having a miscarriage. Now, there are people who have completely out of control diabetes who get pregnant and continue on without an issue at all. But the incidence both of miscarriage and birth defect go up. And so that's why we want that blood sugar to be as tightly controlled as possible around the time of conception, or when we're making embryos and when we're putting embryos back inside of you. Now, IUIs, you got an ectopic. So, with your risk for a recurrent ectopic pregnancy is unfortunately very high after a single ectopic. So when we do IVF, and IVF is always going to be the fastest path to pregnancy and the most reliable path to pregnancy. And so that's one of the reasons that, we kind of say, wow, it's really the solution to a great many problems. But unfortunately, it's also the most invasive and it's the most expensive, so it's something that you kind of have to weigh out. As far as recurrent pregnancy loss, there is a very specific workup that we recommend for folks who have had recurrent pregnancy losses. And one of those things is a panel of blood tests that look for problems in the blood that are associated with blood clotting issues. The most common of which is called a lupus anticoagulant. There's one that's called factor V Leiden. These are the ones that there's one, it's basically called the antiphospholipid antibody syndrome. And this can be tested in the blood. It's an extensive series of tests. It's often kind of expensive, even an expensive, copay when you have insurance, but it's definitely worth doing. And we also like to check your karyotype. The karyotype is your own chromosomes in your blood. It's a simple blood test that we do from you and partner to make sure that there's nothing genetically that's being passed on to your offspring that's resulting in these miscarriages. So yes, definitely. We also want to take a look inside the uterine cavity. That's a very important thing too, because some scar tissue or a polyp can also result in recurrent losses. So Fatima, sure, I'm sorry that you have to go through all that. And as I say each week, to both to you and to all of those out there who are kind of suffering with the very unpleasant roller coaster that is this fertility journey. We all stand with you. Well, it looks like KDB says, I had my second IUI yesterday. How many failed IUIs do you recommend before converting to IUF? Wish you were at the Rochester clinic. Dr. Fink, you're awesome. Oh, well, obviously, Katie, you are very, very smart. Well, I could throw that right back at you. I wish you were at the Colorado clinic, Katie, because you're awesome. What do you think of that, huh? It's not hard to get here. It's really easy. So I don't recommend more than about 3 IUIs before thinking about stepping it up to something else. And why is that? Well, the data actually says about 5 IUIs after the 5th IUI that you are no more likely to get pregnant from IUI than you would be from home intercourse. The problem is IUIs just get expensive, and you just kind of keep doing it. And it's not only the financial cost, it's the damn emotional cost, that every month watching the cycle and coming and providing a, sperm, and then, going through the procedure and then waiting and waiting and waiting for that pregnancy test. And you're waiting and you're waiting and God, can't I just do the pregnancy test? And then you do it and it's negative. Oh. What torture, it's a cruel thing to have to go through. So after 3, I kind of feel like, you've probably just spent nearly as much as you would for a cycle of IVF. And with a cycle of IVF, we have the possibility of being able to get you multiple embryos that can have up to a 60% probability of being able to get you pregnant, as opposed to as opposed to an IUI, which is anywhere from probably a 5 to a 9% probability of getting you pregnant per cycle. So the odds of success are just so much higher with IVF. That's why I say after 3, it's a really hard sell for me to tell you that you should keep doing IUIs. Again, the evidence says 5, but gosh, spending half a year doing IUIs and with the cost, especially at CNY, where now I understand there is actually a summer sale back to $39.95 or $39.99, I think, for IVF, lowest cost IVF in the country. IUI, honestly, is something that you might do a couple times, but certainly beyond 3 doesn't seem like a great idea to me, Katie B. Let's see here. What else we got? We're on to the CNY side. Let's see. Miss K Tan, 42 years old, 5 eggs retrieved and only 1 fertilized. Would you recommend another egg retrieval with the same or a different protocol? Well, I would certainly look at that. I'd say, at 42 to get 5 eggs is not bad. I mean, it's really actually, it's not bad at all. My guess is that you probably did a mini dose, if I had to guess. And so I think, there's different ways to look at these things. And here's kind of what we do at CNY. The first thing we sort of go for is we want to look at what is, if the ovarian reserve is low, then we tend to go for the mini dose side of things. The classic wisdom was with a lower ovarian reserve that we would want to pour as much medication on your ovaries as we could get in order to try to get you to respond. And I'm guessing, at 42, I'm going to be thinking, well, you probably have a lower ovarian reserve. And so in the olden days, they would say, we're going to use these full court press, full throttle, very, very high doses of medication. Well, what's the downside of doing that? Well, one, they are extraordinarily expensive. There are people who could spend $10,000 or $12,000 on medication alone. And there's just no reason that your medication should cost you 4 times more than your IVF cycle. I mean, that's crazy. But sometimes what happens when you use those very high doses, your ovaries don't know what to do with all that stimulation. And so they'll just be like, whoa, I'm shutting down here, baby. I don't know. I'm turning off. We're not going to give you anything. So the data from Europe shows us that if we use mini doses or much lower doses, we get probably the same kinds of outcomes as we would get with the very high doses. So I do not agree in using very high doses. And a mini dose is a fine thing to try, but sometimes it actually makes sense to think about, well, what about what's in the middle there? Is there an age-appropriate dose that's going to be a little bit higher than what I was getting with the mini dose that may get me a different response? And so not knowing anything else about you there, Miss K-Tan, that's what I would think. I would probably want to look at that and say, well, are we likely, I'd want to see what you were on before, and are we likely to do any better if we were to change things around? But I want to tell you that getting 5 eggs is pretty good. And again, the fact that only 1 fertilized is a reality that's associated with that egg quality issue. And so that's why I think things like metformin, the supplements, and Omnitrope may be a good thing for you. Okay, what else is going on here? Haley Gunter, what should we expect at our first consultation? Well, that's a good question. So, when we do our consults over the phone, it's really sort of a situation where we're going to get some medical history, kind of learn a little bit about your journey. Certainly want to know if you've had things like surgeries and are you taking medications? Are there any medical problems that may be standing in the way? If you haven't had an evaluation for fertility, then what we're going to do is order that for you. we're going to check your uterine cavity. We're going to check your fallopian tubes. We're going to order a bunch of hormonal blood tests to kind of see where you are, where you're starting, and what your possibilities are. We will generally then also talk about what the possibilities are for treatment. So that's things like timed intercourse versus an IUI versus IVF, and what those different things mean. We kind of go over the process. The testing can be done locally where you are, or it can be done in one of our office, but we sort of go over how things work as far as whichever treatment that you're going to do, and how we interface with that, and what we would like to do in order to try to get you pregnant. And hopefully we come up with a plan by the time we're done with that consultation. And then we just kind of get the ball rolling. Usually then our team will reach out to you, get the materials into your hands that you need, the prescriptions and whatever else it may be. So it's pretty low key. It takes, we get 30 minutes allotted for a consultation. And then sometimes we need a follow-up after that. But if we know what we want to do, if we know how we want to do some treatment, then we go ahead and put a treatment plan in place for you, so that it just saves you some money from having to do another consult, and also just takes less time for you to get to the point where we can try to get you with a baby. So I hope you will enjoy that consultation experience. Let's see, going back to the Fink CNY side here, Miss K says, feeling so good and all the positive vibes from transfer today. You had your transfer today. Outstanding. I am so glad. We will keep our fingers crossed. Yeah, baby dust to you, my friend. Is there any difference? And this comes from, it looks like a Maddie, I believe. Is there any difference between donor, fresh, and frozen transfer? Which gives me a higher chance? Well, I think what you mean by that is that you are planning to use donor eggs. And if you're going to use donor eggs, then you have a choice of selecting either a fresh donor cycle or or some frozen donor eggs. So as you can imagine, there are tens of thousands of donor eggs that are on ice that are waiting for people who want them. So once you've selected your donor, the difference is, well, so for example, when we freeze embryos, the success rate of freezing and thawing an embryo is about 97%. It's really high. Now, it's not 100%, so sometimes we do lose embryos when we thaw them. But an embryo is a little functioning machine. They freeze and thaw. That science, that technology has come a long way, and we really know how to do that. So freezing an egg is not always as successful. There are some studies that say you may only get a 50% recovery. We expect about an 80 to an 85% recovery. So the difference with a donor cycle is that if you pick a fresh donor cycle, there's going to be probably a little bit of a wait list or a little bit of a delay because of getting that donor all teed up and cycling and stemming and retrieving. But let's say that you purchase 6 eggs. Well, you are going to get 6 viable eggs. They're not frozen, they're fresh. Now, they may not all fertilize because in nature, that's just kind of the way things is, and that's nobody's fault. It just happens that way. But you're going to get all 6 eggs and at least have the chance to try to fertilize all 6 of them. If you are selecting frozen donor eggs, then those eggs have to be thawed before you can fertilize them. And let's say you pick 6 eggs, you may get 100% of them. They may all thaw and be fine. Or you may get 4 or 5, that you may lose 1 or 2 as a result of the thaw itself. So that's really the biggest difference between fresh and frozen donor eggs to make an embryo. But once they are fertilized, as far as success rate, doesn't really matter where they came from. Now, if you're talking about fresh versus frozen embryo transfers, I will tell you that people get pregnant from fresh transfers every single day. In fact, so much so that CNY includes that fresh transfer as part of the cost of IVF. However, a frozen transfer is always going to be a little bit more effective because even in the best case scenario, your body was in egg making mode when you went to try to make those eggs for retrieval. And egg making mode just doesn't always equate to being pregnant mode. But I think what you were asking me about was donor eggs there. Maddie, good luck with everything there. This comes from what Mr. Likes. My first transfer failed in June. What are your thoughts on acupuncture before next transfer? I feel very strongly about pre and post transfer acupuncture. In fact, here in Colorado, and I know in Syracuse, I believe in Albany as well. Not sure about Buffalo. Acupuncture is available on site for transfer, so very strongly recommended. There's some good evidence that it's helpful. Oh, here my friend Kirsten is on the line here, and she's 29 years old with one kidney. So there you go, my friend. I hope that's good news for you. Thanks, Kirsten, for sharing that. Over back to the Facebook side here. Let's see, 47 years old here. This comes from Luciana. Should I try an egg retrieval? Well, I will tell you, above about the age of 45, the odds of success of getting a pregnancy and having a live birth through IVF are very, very small. I won't say there's zero, because it can happen. And here at CNY, we do, sometimes up to 20,000 cycles a year. I do more retrievals here in my office alone than most IVF center doctors will do in an entire year. So, our volume is very high. And so we do see people of what we'll call advanced reproductive age. We do see them getting pregnant, but the odds are not good. So, Luciana, if you were going to do it, I would say, maybe you do it so that you can convince yourself what the reality is going to be for you. In most clinics at 47, they would tell you, nope, we're not going to let you do it. We don't want to, odds of you getting pregnant are so low. We don't mess up our perfect numbers. Well, at CNY, we don't report that. We do report it, but we don't care about it, because we take anybody and everybody who wants to have a baby, because it's your right. It's not my decision. What I wouldn't want you to do is to, cycle again and again and again and think that if you just change something in your protocol, that somehow magic is going to happen, because it's a question of the biology. It's just the sort of the way nature works. So I think it's certainly worth talking about, but I want you to have very, very realistic expectations. Well, Christine Rousseau is here with us. Hi, Christine. Oh gosh, this is sad news. I just lost a pregnancy at 9 weeks that was PGT tested and normal. However, the fetus had a yolk sac that was too large, which is indeed suggestive of a chromosomal issue. What are the chances another quote unquote normal embryo is not again? Well, so there are some specific numbers on that. And remember, the way that PGT testing is done is that they are biopsying the portion of the embryo that becomes the placenta. And it is possible to have a mismatch, to have a normal placenta with an abnormal embryo. In fact, it's possible to have a normal placenta with no embryo at all, with no baby growing on the inside. That's called an inner cell mass. And that results in what's called a blighted ovum. So it's possible for the placenta to be normal and the embryo to not, or vice versa. It's possible for the placenta to be abnormal and the embryo to be normal. There are a bunch of studies that quote different numbers on these things. And so it's anywhere. So to go from the to have an abnormal placenta with a normal embryo still gives you anywhere from a 5 to up to a 15% chance of having a normal baby. So that's why PGT testing is not perfect. Same thing. What are the odds of having a tested normal embryo with an abnormal chromosome? Well, it's thought to be, it can actually be up to 25%. So now, in general, that's not the expectation. The expectation is that that the true false negative rate on that is much lower, and I think you can feel pretty comfortable with that. But gosh, what a very scary and unpleasant thing you had to go through there, Christine. And I sure am sorry to hear that that's the way that that happened. Okay, let's see. Can we test for inflammation? And how can we reduce it? So, well, if you talk with Dr. Kiltz, he will tell you that the best way to reduce your inflammation is through diet. Diet makes a difference. Antioxidants make a difference. And can we test for inflammation? There are some markers in the body that we can see that show us inflammation. So that's part of those initial tests that we do, the preconception tests. I'm looking over here at my Instagram with 3 minutes left till the top of the hour, and I would like to say hello to my beautiful mother, once again joining from Southern Alabama, the great city of Mobile. Thanks for watching. Okay, there we go. I had to. Let's see. We have a question here. Does anyone know if we get to pick which location we go to? Yes, absolutely. You can decide which location is the best for you. Sarasota was originally going to be open as of July the 1st, and then that got pushed back for some inspection things that they're still kind of waiting to get done, and that has to get done before the next step gets done, and then the next step and the next step. But certainly by the fall, we expect Sarasota to be open for a full service. We're here in Colorado Springs. Also, IVF is done in Syracuse, Buffalo, and Albany. We have monitoring centers in Rochester, in Miami, in Philadelphia, and Atlanta, and really sort of all over the map. By the way, if you're curious, if you go to the CNY Fertility, actually just Google CNY Fertility Travel, you can put in your location, and it will tell you any of the monitoring centers that are near you, places that have worked with us before who know what we are doing. I've started Oralissa for about 60 days. Was told that I can go for my baseline the day after I finish Oralissa, and it's unnecessary to wait for my period. Yes, that's exactly right. Now, the only thing to know there, Shanna, about Oralissa is that it may delay your cycle a little bit. So doing a natural cycle embryo transfer after Oralissa may be a little bit of a challenge. Because you may be a little suppressed and you might not ovulate in a normal fashion. So usually after that, I recommend either a modified natural with ovulation induction or that you do a medicated cycle. Well, it looks like we're going to run out of time here. Once again, gosh, it was so nice to see everybody. We've got about a minute left till the top of the hour. The thing that I always close my show with here is a very important reminder, and I want to make sure that you hear me, that fertility is not your book, man. It's not your novel. It is not, you are not the cover story on that magazine. It is merely a chapter in your life, and it's a chapter that we are here to help you rewrite every single day. That's what we do. So from me to you, God bless everybody. Thanks so much for being here. I'll look forward to seeing you next week. Next Tuesday, 4:00 p.m. Mountain Time, 6 on the East Coast. It's Fertility with Fink and Friends. And until then, Thanks. Good night.